So I'd like you to sort of think about stomach cancer and break it really into two categories. So one is localized, meaning could a surgeon remove the cancer? If that's the case, we use multimodality treatment, including surgery, chemotherapy, and radiation. The other branch point is this cancer unresectable or metastatic, in which case only chemotherapy will be used for treatment. So let's talk a little bit about chemotherapy or treatment for localized disease. There are actually a few options. I've presented two main options here. So one is considering surgery first, followed by chemotherapy and radiation. I've given an example of a chemotherapy that's used commonly here, which is one that is available in sub-Saharan Africa, 5-FU. And then chemotherapy followed by surgery, followed by more chemotherapy is another acceptable approach. In fact, that's probably more commonly used. The pendulum is probably swinging towards that. I've listed some chemotherapies here, which also, many of which are available to you. Treatment for metastatic disease, as I'd mentioned, is chemotherapy only. Once a cancer has spread from where it started, whether it goes to the lungs or the liver, it is no longer curable. I should mention in the context of this that as I'm talking with patients, I try to be very clear when I first meet them, talking about what the goals of treatment are. So if they have a localized cancer, we talk and say, well, the goals of treatment are curative, versus if their cancer has already spread, we'll talk about how the goals of therapy are palliative, really hoping to give them as much time, but have that be good quality time. So in terms of access to chemotherapy, as I'd mentioned in some of those earlier slides around that New York Times article, and some of the efforts with the American Cancer Society, two companies came forward in late 2017 to try to provide lower cost chemotherapies to many African countries. These specific chemotherapies are listed here. You do not need to memorize these, but in bold, I have put some of the chemotherapies that are used commonly for stomach cancer. So I suspect that many of these may be available, though not widely. So let's talk just briefly about some of the side effects of chemotherapy. So chemotherapy gets a bad rap. Not all chemotherapy is all that hard. And I think with appropriate supportive measures such as anti-nausea medicines, that can be easier. So fluoropyrimidines include things like 5-FU. Capecitabine is an oral form of that. 5-FU is infusional. These can cause nausea, diarrhea, something called hand-foot skin syndrome, which is a dryness and cracking of the palms and soles. The platinum class of chemotherapies can cause nausea, neuropathy, such as hearing loss or numbness and tingling in the fingers and toes. Cisplatin can cause nephrotoxicity and myelosuppression, which includes lowering of blood counts. And then oxaliplatin, which is another platinum, can cause some of those same side effects. And then taxanes, another class, which includes one called paclitaxel, can also cause nausea, neuropathy, and lowering of blood counts. We talked about radiation in the context of gastric cancer. It's not an absolute requirement. Chemotherapy alone before and after surgery is acceptable. Post-operatively, radiation is still sometimes used. Based on sort of my digging around a little bit, it seems that access to radiation is probably fairly limited in much of Africa, and so that it may or may not be available to you. I would say that also in terms of treating patients with metastatic disease, we will sometimes use radiation to help treat painful bone sites. Sometimes using radiation to the esophagus can help open that up and help patients swallow a little bit better. Side effects of radiation include skin toxicity. So think of it like a bad sunburn. The skin can become blistered and red and peel. On the inside, so if we're radiating the GI tract, the stomach and the esophagus, can cause something called mucositis. So that's like a sunburn on the inside, nausea, vomiting, and one of the most common side effects is fatigue. So let's say that we get our patient all the way through a surgery and chemotherapy that was for curative intent. We would then move into a phase called surveillance, where we want to monitor the patient. Generally, we would, and this is per the NCCN guidelines, we would do an H&P every 3 to 6 months for 1 to 2 years, then every 6 to 12 months for 3 to 5 years, and annually thereafter. The CBC and chemistry blood tests are done as clinically indicated. And EGD, that esophagogastroduodenoscopy, upper endoscopy, is also only done as clinically needed. And CT scans are done every 6 to 12 months for the first 2 years, and then annually for up to 5 years. And then we also recommend monitoring for nutritional deficiencies because of after a gastrectomy, patients are at higher risk for B12 and iron deficiencies. I'd like to touch briefly on the principles of survivorship. So this is a relatively new field in cancer, where the definition of cancer survivorship is thinking about how to take the best care of the patient before, during, and after their diagnosis, really focusing on patient well-being. So we talk about managing long-term sequelae of disease or treatment. General issues include things like weight loss, diarrhea, chemotherapy, chemotherapy-related neuropathy, fatigue, and bone health. Specific issues for gastrectomy survivors include indigestion, B12 deficiency, distal gastrectomy, and iron deficiency. And we also counsel patients regarding health behaviors, include routine cancer screening, and then survivorship care planning and coordination of care. This also helps really bring in patients' primary care physicians, engages them in some of this monitoring and follow-up.